everyone. Welcome to the Washington County Long-Term Care Collaborative August meeting. Today we'll be focusing on outbreaks and getting ready for next respiratory season for this coming fall and winter. Although with COVID, it feels like it never went away. So we have a full agenda today. So do we want to do a quick round of introductions, Bridget, or just get started?
Sorry, yes, I'm having trouble with the recording. Yes, please do introductions.
Okay, perfect. So we'll try and do this quickly. I have about 5 minutes. So I am Wendy Taylor, the nursing supervisor here at Washington County Public Health Department. Let's go ahead and have our nurses. We have one nurse missing today, but we'll go ahead in alphabetical order. Jenny, do you want a quick introduction?
Sure, I'm Jenny or Jennifer Robertson. I'm one of the communicable disease nurses.
Layla?
Hi, my name is Layla Rais-Dana. I am also a communicable disease nurse.
Sue?
Hi, my name is Sue Leong. I'm also a communicable disease nurse.
Songhae?
Hi, my name is Songhae Boko. I'm one of the city nurses.
And Trisha?
I'm Trisha Phillips, and I'm one of the CD nurses.
Next, we'll go to our EPI staff. Siobhan, do you want to lead us off?
Hi, my name is Siobhan Burns, and I'm a communicable disease epidemiologist in our RAID division. I'll pass it to Jonathan.
Thank you. My name is Jonathan Gertzen. I'm also a communicable disease epidemiologist in our RAID division.
Great. Do we have any other EPIs on the call or just you two?
I think it's just us, right?
Yeah. Okay, I don't want to skip anybody.
Kathleen's here.
Kathleen?
Oh, my bad.
Hi, I'm Kathleen Race. I'm a EPI supervisor with Washington County. Good morning, afternoon. Should we pass it to the coordinators, Wendy?
Yep. Yeah, sounds good. Well, Bridget, do you want to go ahead?
Sure. Hi, I'm Bridget Monterossi. I'm a senior program coordinator with the Disease Control and Prevention Program.
Great. And is Tyler here?
I am. Good afternoon, everyone. Tyler Slattery. I'm also a senior program coordinator with our communicable disease team. Thanks all for being here.
Yeah. And Sam?
Hey there, I'm Sam Lathrop. I'm also a senior program coordinator with Disease Control and Prevention, and I do all of the immunization program.
Wonderful. Let me open it up to others here. I think we have a Ryan Frick. Frink? Excuse me?
Yeah, Frick. Hi, everybody. I'm Ryan Frick. I'm a population health epidemiologist with APD at ODHS. So yeah, I'll be presenting later. So thank you for having me.
That will be good.
Wonderful. Therese? Where's Therese here? Sorry. Therese?
She was.
I wish I had $1 for every time I do that. My name is Therese Finn. I'm the Oregon Health Authority's HAI MDRO infection preventionist for Western Oregon. And so I cover any MDRO high-risk MDRO pathogens that occur or any MDRO clusters that occur.
Wonderful. Anyone else from the state?
I actually have my counterpart, Mary Edmondson, who would like to introduce herself.
That'd be great.
Hi there, my name is Mary Edmondson. I am the HAI infection preventionist for Region 1 and 2. So taking over Therese's previous role in working with respiratory outbreaks like flu, RSV, and COVID, as well as different GI illnesses. So I probably will introduce myself a little bit later as well, but if you guys need anything as far as those are concerned, I'm always happy to help. Thank you.
Welcome, Mary. We'll see you tomorrow too. Okay, have I got all our presenters? Did I miss anyone?
I think you got everybody.
Okay. Wonderful. I don't know if we want to open up to anyone else, the participants, or just move on, Bridget. Either way.
Yeah, I don't think we have time. So I would just like to, let's send it over to Jonathan.
Awesome. Thank you folks for joining us today. I get the privilege of being able to provide you a quick update on some data that was shared at the last Learning Collaborative and some information that may help kind of build support for vaccination at your facilities or in your communities. We're going to start with a review of influenza outbreaks over the last 9 months. This chart from the Oregon Flu Bites report shows the number of influenza outbreaks in Oregon by setting for last year's respiratory season, which the Oregon Health Authority set as October 1st, 2023 to March 30th, 2024. Influenza outbreaks have been reported outside of the viral respiratory season, as we see them occurring in May, June, and even July. Hospitals and long-term care facilities represent the greatest number of influenza outbreaks in Oregon. These settings have both similar and unique risk factors, including age and underlying health conditions, while folks in hospitals are there because they require more immediate and a greater level of medical care. We continue to only track outbreaks in congregate and other high-risk settings, like hospitals. This graph shows the percent positive of influenza tests by season as reported through the Oregon Influenza Laboratory Surveillance Program. These Sentinel labs are critical in providing baseline data that allow health officials to determine the onset of flu season as well as estimate the burden of disease in the community. The 2022-2023 flu season had a very early onset in mid-November, which is very unusual. This year, we are closer to matching the 5-year average or trend with a more typical start to the flu season in mid-December. But as you can see, there's been like a low persistent level of positivity that's been kind of sticking with us through July and August. This chart shows the rate and distribution of influenza-associated hospitalizations by week and age group in the Portland metro area. You can see that we have had a steady increase since November, peak in January, but are still seeing influenza-associated hospitalizations in August. The reports for these visuals go back to 2008, and we have not recorded flu hospitalizations this late in the year, or this far after the flu season. With 355 influenza-related hospitalizations, folks who were 65 years and older at the time of hospitalization continue to make up the largest group of people at 50% of all influenza-associated hospitalizations. To do our best to protect the most vulnerable, we should encourage anyone eligible to get their annual flu shot. That includes staff as well as residents. Thank you to those who provide vaccination clinics at your site. Ease of access is a major factor that contributes to staying up to date on vaccinations and can help normalize the practice of vaccination in your community. For flu, vaccination rates are lower over the last 3 years compared to the peak during the pandemic. From this chart, it is easier to see just how much lower the vaccination rates are from last year, with the state reporting 1.3 million influenza immunizations administered since July 30th, 2023, compared to 1.4 million flu shots administered at the same time last year. 2020-2021 retains the title for most flu shots during these periods of time. Vaccines have had a huge impact on humanity over the centuries. It is no different in the US. The CDC estimates that during the 2022-2023 flu season, flu vaccination prevented 6 million illnesses, 2.9 million healthcare visits, 65,000 hospitalizations, and 3,700 deaths. The Center for Vaccine Development and Global Health estimates that from December 2020 to November 2022, COVID-19 vaccinations prevented $1.15 trillion in just medical costs, 120 million illnesses, 18 million hospitalizations, and 3 million deaths. These estimates are only through November 2022, so the numbers will likely increase drastically when this analysis is performed with updated data. This kind of analysis hasn't been performed yet for RSV vaccine because it's newer, but once that information is available, we'll certainly share that out with folks so people can get a better understanding of how helpful vaccines can be. This chart shows the rate and distribution of RSV-associated hospitalizations by week and age group in the Portland metro area. RSV impacts newborns and children under age 2, folks who are 65 years or older, as well as people who are immunocompromised. Everyone who is eligible for the RSV vaccine are eligible because it helps them avoid the complications which require hospitalization and may result in death. RSV season ended March 30th, 2024 because PCR test positivity was below 3%, and antigen test positivity was less than 10%. You can see there were cases after that date. Now, getting to Washington County specific, during this last respiratory season, COVID remained the primary driver of respiratory outbreaks in long-term care facilities. From October, almost all reported outbreaks in congregate settings were COVID, a total of 76 outbreaks reported. A single flu outbreak, 2 RSV outbreaks, and 2 GI outbreaks were also reported during the same period of time. Respiratory outbreaks are very difficult to stop once they have started, so implementing masking early, isolation, testing, and getting prophy for those that are sick are very important. Long-term care facilities represent a greater concern for serious outcomes, including death, if these outbreaks are not detected early and effectively managed through staff and resident testing, post-exposure prophylaxis, and implementing infection control procedures. We can help advise you and provide support, so do not hesitate to reach out. As I said earlier, we only had 2 G outbreaks for the 2023-2024 respiratory season. But please remember that most GI outbreaks are caused by norovirus, which are low dose and spreads easily. So it just takes a little bit of someone's bodily fluids to contaminate a surface, stick around, and potentially infect many other people. Cleaning up vomit or fecal material is a priority, and please ensure once the surface has been cleaned, a disinfectant is applied for the recommended amount of time. This may require rewetting a surface to avoid having the disinfectant evaporate before the kill time is achieved. And out of respect for time, that's what I also provided some updated slides at the very end, then will be shared out that folks can review after this meeting. And I will pass it off to our wonderful nursing team.
Thank you, Jonathan. Okay, so I think, let's see, we have Sunghae up first, Layla, Jenny, and then Sue, and I'll share the document.
I can go ahead and just lead us off, get us started on that too. You want Bridget?
That'd be great, Wendy. Thanks.
Great. Thank you for sharing the document. This may look a little familiar to some of you or possibly not. Maybe you're new, but this is our long-term care facility, or what we call long-term care and adult foster home outbreak guidance. And it's meant to be a quick guide to understand how to contact us, when to contact us, and the basic pieces of information we will need from you. There's also hyperlinks within this document that can lead to other sites such as the Oregon Health Authority or our own website with more information. Otherwise, we would love to, when you give us a call, we will also provide you more information and walk you through the process. We're here to support you through these outbreaks. I know there are many, as you noticed, many COVID outbreaks continuing, and we anticipate that'll be the case coming up for this 2024-25 season. We've broken down some of our nurses to present certain parts of this guidance. So I'll go ahead and pass it off. I believe Sunghae is the first one, correct?
Yeah.
Okay, take it away, Sunghae.
Hi, I'm gonna talk about when you guys contacted the Washington County Public Health to report any suspected or confirmed disease outbreaks. So first is gastrointestinal illness with vomiting or diarrhea. So if there is 2 or more residents or facility staff with GI illnesses within 3 days of each other in the same cohort, or a single case of the GI illness with a bloody stool that cannot be explained by another non-infectious cause. So for example, someone who has hemorrhoid, that does not count in of this situation. So the other one is a respiratory illness with a fever, cough, sore throat, or positive test result. So one confirmed influenza, RSV, or COVID-19 case with others ill with respiratory illness in the same cohort, or 2 confirmed or presumptive cases of influenza, RSV, or COVID-19 in a 7-day period in the same cohort, or chest X-ray confirmed pneumonia in 3 or more residents. In that case, you should let us know. It can be one of the outbreak. The other is unusually high absenteeism by staff complaining of related symptoms. So if you have the two staff member is calling sick and then they have a similar illness that can be related to some outbreak. So then you have to let us know. And then the other one is 2 or more residents or staff with a high fever that cannot be explained by another known issue. So if somebody has some constantly have high fever, it's not the new one. It's not going to be really issued at this point. Or someone who has a dehydration that was cause of the fever, that is not their one. So it is more cannot be explained by another known issue, then you have to let us know. And the last one is any hospitalizations or death related to a current outbreak or 2 or more hospitalizations and or death among residents or staff with severe or similar symptoms. So if you have those kind of cases, you should contact the Washington County and then let us know about that one. Next, I'm going to pass to the Leila to explain about when you report us, what kind of information we need. So, Leila.
Good afternoon, everybody. So when you do call to make a report, we will have some questions to help us evaluate whether the illnesses occurring at your facility are in fact due to an outbreak. So we'll ask you some information about the building itself, the built environment. So total number of floors, units, dining rooms, kitchens, wings, and or buildings. I know some places have cottages and things like that. We'll also be asking about the total number of affected floors, units, dining rooms, kitchens, wings, and buildings, as well as the total number of residents, facility staff, and if it's a GI-related illness in the building, number of food handlers who are in the facility, who are ill or absent, living or working on the affected floors, units, wings, and or buildings, and floating between floors or units. We will ask about symptom profiles, types of symptoms, onset dates, and duration of illness, and a note here to distinguish between gastrointestinal and respiratory symptoms as early as possible. And then we want to know about anyone who has been tested, if they have a lab confirmed illness, if anyone was hospitalized overnight, and if there were any deaths.
Thanks. And
thank you.
Jenny, I think you're going to go over, because Therese is going to cover the prevention and you're going to go over what to do during the outbreak.
Right. Our outbreak guidance is aimed at preventing other residents and staff from becoming ill. So we'd like you to send home any staff members who develop symptoms at work, isolate ill residents to their rooms, exclude ill visitors, exclude staff and isolate residents with respiratory illnesses according to the guidance in the at-a-glance infection control for respiratory pathogens. And that there's a link to that document in this document. And it's got all sorts of information on it that's pretty helpful. Increase hand washing with soap and water. Hand sanitizer is not effective for GI outbreaks, so hand washing is really important. During respiratory outbreaks, use alcohol-based hand sanitizers frequently if soap and water is not available. Encourage use of PPE. Ensure food handlers are wearing clean gloves and using utensils when serving ready-to-eat foods. Follow the cleaning and disinfection guidance for your facility. And there's also a link to that document or a document on that in our document. Provide appropriate antiviral treatment immediately to all eligible residents with influenza or COVID-19. Provide antiviral prophylaxis for eligible exposed residents during influenza outbreaks. During an outbreak, regularly provide an updated line list and or daily count of new illnesses or absenteeism. For respiratory outbreaks, a complete line list of all the cases is required. For GI outbreaks, we only want to know about the first 10 residents and staff, so 10 total, after which only a daily count of new cases or any hospitalizations or deaths is required. Washington County Public Health will provide disease-specific guidance, and I think Therese is going to cover that a little bit as well, including disinfection and cleaning, preventing disease transmission, exclusions, testing, case definition, education for staff and residents, recommendations for seeking medical care, notification of outbreak, investigation closure, and other information as needed.
Great. Thanks, Jenny. And Sue, you're going to go over the flow chart.
Yes, thank you. So this document has 2 pages. The first page, lists things up, and the second page is a flow chart. Everyone learns differently, remembers differently. So my coworkers have covered what it is, when to call us, the different boxes, whether it's a GI, respiratory, is it unusual high absenteeism in your staff, complaining about related symptoms. So that first blue squares definitely is when to call us. Then we have our contact information. And when you call us, we also need to know certain information like the total residents and staff you have, the total ill residents and staff or food handlers. Really, the goal is so that we can assess what's going on. And then this orange box has what Jenny has covered of, the different prevention, what to do, exclude isolation of residents and staff. If we open an outbreak, then we would need regular updates on what's going on, whether anytime you have a new case, we would like an update from you by updating the line list. Again, really it's about surveillance and identifying any sudden change. If we see a sudden increase in numbers, we want to assess what are some of the control measures are in place and what are some of the control measures that are not in place that we want to review. So really our goal is to prevent additional cases from happening, and all this information that you give to us helps us assess the situation and help your facility to stop that spread of that infection. If we do not open an outbreak for certain situation, for example, COVID, with one case, we do not open an outbreak, and that's fine. Sometimes you need, the control measures should continue to be put in place, or you have questions, definitely reach out to us. But once you hit that threshold, then we would definitely want you to call us. So this flow chart really just summarize page 1, but more in the visual for those who are visual learners. Thank you.
Great, thank you, Sue. Okay, I'm gonna stop sharing and send it over to Siobhan to share with us a little bit more about the line list.
Sure. Get this ready to go here. Sorry for a little delay. Okay, here we go. All right, so reiterating what the nurses were saying about when to call in, I just want to go over really quickly, definitely things that on the epi side that we're looking at as potential indicators of a major outbreak or something of greater severity. So as far as respiratory outbreaks, we're definitely looking for anything that involves pneumonia in the 3 or more residents, that shortness of breath, high fevers, and any overnight hospitalizations. And this includes staff or residents at the facility. Residents of long-term care facilities represent a very vulnerable population that are likely to have multiple underlying conditions that might increase their risk for poor outcomes. This could include heart disease, diabetes, or other conditions like liver, kidney disease. CDC reports that more than 81% of COVID-19 deaths occur in people aged over 65, and the number of deaths among people over 65 years is 97 times higher than people in the age group of 19 to 29. So we're particularly concerned if residents develop these specific symptoms. Again, this is something you would want to call in and let us know what's happening. If a resident were to die due to complications of COVID, please also note in the line list any underlying conditions that you know of that may have contributed to their death. Severe outcomes may signify that a new or emergent strain is becoming more pathogenic and require increased disease surveillance. GI outbreaks are very common in congregate settings. Many GI outbreaks are caused by norovirus, which typically has a rapid onset, marked by vomiting, diarrhea, and occasionally low-grade fever. Symptoms will typically resolve within 24 to 48 hours and generally do not cause significant long-term sequelae. If a resident is experiencing high fevers or bloody stools or is hospitalized for complications like severe dehydration, please notify us immediately. Also, you'll want to send an updated line list if you have reports of additional cases, especially if you start seeing these hospitalizations or deaths in the residents. If there's no major updates, our CD nurses will check in about weekly to find out how the outbreak is progressing and also offer any additional assistance if needed. Please make sure that you respond to our emails regarding your outbreak status at the end of the monitoring period, and this is how we know we can close the outbreak. If there are new cases, we will reset the monitoring period accordingly and then follow up with additional emails. I'll go ahead now and pull up, I'm going to stop sharing so I can share my screen with you. So this is a sample respiratory case log that I drafted. Here is where you'll receive this from our nurses once they've opened an outbreak. You'll notice up here, you'll have your facility name. If your facility has multiple locations, like maybe you have one in Hillsborough as well as one in Beaverton, make sure that specific location is specified so we know the precise location where the outbreak is occurring. Your outbreak will always start with the year and then it'll be followed by another 4-digit code that's automatically assigned when we open the outbreaks. The information that we're really looking for here is the staff name, so their last and first name, their date of birth, the sex if known, race if known, and then you're going to also code out if they are a staff, a resident in food service, maintenance or facilities. And here I made a mistake. This should be F. Oops, sorry. F for food service, because this is a food service workroom. And where their specific location is. So for this first resident that we had symptoms in, they were located in the East Wing. If it's a staff person, we want to know, are they working in a memory care unit? Are they floating? Do they specifically work with a certain population? And do they have direct patient care? We also want to know the last date worked for any of the staff. If they have symptoms or if they were asymptomatic, if they had a fever, if it's known and it was above 100 degrees, that'd be great. If it's just subjective, you can enter that in. Cough, shortness of breath. We're not seeing new loss of taste or smell as much. We're seeing actually more diarrhea reported in a lot of the COVID that's been going around this summer. So you may or may not know some of these symptoms. If you don't know, you can go ahead and just leave them blank. If you scroll over, you will notice that you can enter in information here for other symptoms. If their COVID test was positive, if this was done at home, or if this was done on site. If they were sick with anything else like influenza, strep throat, anything like that, you would want to add that information here. If you know their vaccination status for influenza as well as COVID-19. If they end up hospitalized, please also enter in which hospital they're located at, the hospital admission date, as well as their discharge date, and any other pertinent information. The notes section is also really important. This is where you would want to add in anything related to pre-existing conditions. Or, for example, this person was the roommate to our index case. Another person, they were tested positive upon arrival for their shift, so they did not work that shift. They were sent home, so then we'll look at their last date that they actually worked as their last exposure date to any other staff or residents. I put in the example of somebody being a nurse supervisor, so they're floating between the wings. And then the last one was a food worker. So this person, I just made up an example that they're the sous chef, but they do have an underlying condition of COPD and asthma that may place them at higher risk. If you click on the summary tab, you'll notice that it'll automatically tally up any of these, any of that information that you add in about if they were tested positive for COVID. It will not automatically refresh the graphs though, but if you right click and click refresh data, it'll automatically update all of this data. You actually don't need to necessarily worry about that. If you're curious and you want to look at your epi curve, you can do that. But we generally take care of it on our side. But it is something that if you're interested in looking at how your outbreak is progressing, it can provide you some information there. We are also working on updating our GI log. It is going to look relatively similar to this, but the symptom profile is going to look different. It's going to be specific to gastrointestinal illness. Again, we shouldn't be seeing high fever. We shouldn't see bloody stool. If we're seeing any of these more severe symptoms, that's when we know we need to do a little bit further look and start maybe looking into doing an ICAR. So are there any questions? And I'll pass it back to Bridget.
Yeah, and feel free to put questions in the chat if you have them, and I'll turn it over to Therese to share some infection prevention information with us.
Thank you, Bridget. I just hot off the press is some information about obtaining free COVID tests again this year. So I'm just going to drop that into the chat if you know that's helpful you to communicate to your staff. And let me just share my screen here. Hang on a sec. Okay, can you see my screen okay?
Yes, we can.
For some reason it's not. Oh, there we go. Okay, so I'm going to be talking about some infection prevention activities for respiratory season. My contact number information is here. I would welcome having you reach out if you have any questions or if I can support you in your infection prevention program. I do always like to start by my favorite part of infection prevention and control is the prevention part. So as with a whole host of communicable diseases, prevention really is key. So please be proactive, you know, vaccinate yourself and others, have a response plan for that first case. Make sure that the practice of respiratory etiquette is wired into or engineered into your facility by making sure that you have the equipment and tools and signs in place where they would be needed. Emphasize hand hygiene, not only for staff, but it's very important for your residents as well. And then making sure that, you know, you're routinely cleaning and disinfecting your surfaces and equipment. I like to think about this as having a toolbox. So I'm going to approach this as each component is one of the tools in your infection prevention respiratory toolbox. And the first thing I'd like to talk about are some really valuable quick references that are available. And I believe Bridget's going to drop links to these documents into the chat as I go through. Now, the first one I want to just touch bases with you on is the at-a-glance infection control for respiratory pathogens. This is a really good resource to help you identify for the organism what precautions you should be implementing, the specific personal protective equipment that's required, the key elements of donning and doffing, and then the duration of precautions, as well as return to work criteria. So this is a great tool that covers SARS-CoV-2, influenza, and RSV. The second really good resource is this is a 10-page document called the Interim Summary of Long-Term Care Facility Infection Control for COVID and Respiratory Pathogens. And this document has a lot of really rich and valuable information from screening and visitation that you can see here, but also hand hygiene, ventilation, disinfection, communal activities, masking, hand hygiene. It just kind of covers the whole gamut for you. So a very good tool. And then lastly, is this respiratory season guidance for you when you're admitting hospitalized residents back to your facility in long-term care. So it's a good reference for admission and readmission testing, as well as conditions for returning to the facility. I'm not going to go a lot into detail about vaccination because that's going to be covered shortly. But again, reminding your staff that when you are vaccinated, you protect yourself, you protect your family and friends, but also those very vulnerable patients and residents that you care for. Now, I like to start by just saying that being aware of what's going on in the community where your facility is really important. And there's a very nice tool available from the CDC called the Respiratory Illnesses Data Channel. And that tracks national and state level spread of COVID, flu, and RSV. And I gave you a screenshot here and basically typed in the state of Oregon. For this one, I happened to put in Multnomah County. And then at the bottom, you can see that when this was done, flu was decreasing in the community, and there was a consistency of cases between for RSV and COVID-19. So no change. And this is really helpful for you to keep an eye on what's going around you, because what's going on in your community is likely to enter your facility. Education is really important, and doing this now will really have long-term benefits for you. I've seen a couple of facilities that during this preparation period for respiratory season put together infection prevention skills fair, which seems to work really well. So I'd encourage you to think about that. And with that education, ensure that you're covering those key elements of PPE donning and doffing, the importance of hand hygiene with alcohol-based hand rubs for patients and staff, cleaning and disinfection practices, your patient management practices, again, to reduce the risk of resident-to-resident transmission. There's some great ways that we can work to improve indoor air quality and dilute virus that's suspended in the air. And also reviewing with your staff and patients, residents, signs and symptoms of flu, COVID-19, and RSV, making sure that your staff are familiar with your facility or organization's sick policy and what they can expect to have when they return to work after being ill with one of these viruses. And again, don't forget residents and visitors in that education. So universal masking is something that's a really valuable tool, and it's important to make sure that when you see those increases of cases in your community, that you consider implementing universal masking, because it does lower the risk of respiratory virus transmission and protects your healthcare workers so that you don't end up having significant staffing shortages and need to move toward, crisis staffing measures. Universal masking is very effective during periods of high community activity and outbreaks, but it's important to choose the right mask for the activity that is being performed. So number one, you want a well-fitting medical mask. If the staff is taking care of an individual with a respiratory infection where the virus is unknown, You want them to be caring for residents using an N95 respirator and including fit testing as part of your respiratory protection program, as well as your staff knowing how to perform a seal check. And these images down below demonstrate proper donning of that mask and performance of a seal check. I do want to mention a little bit about KN95s. I've come across a lot of people who really like them because they provide a good fit and are comfortable, but it's important to monitor that they're not being used for the care of symptomatic or COVID-19 positive patients or residents. So, and the important thing is again, if you don't know what the organism is that's causing the symptoms, then you should really be working at the highest level of protection, which would be for COVID-19 and following that COVID-19 guidance. It's important that people wear their masks properly and that you're encouraging others to do the same. And that means that the mask covers the nose, mouth, and chin and is not down underneath the chin or, leaving the nose exposed. It's also important to instruct folks to clean their hands before they put their mask on, after it's taken off, and anytime after touching it. I also like to mention that it's important to avoid using masks with valves, because what happens is if I have a valve on my mask and I exhale, that valve will pop open, and then I am exhausting whatever's in my respiratory tract into the environment around me. A word about COVID testing. When someone is symptomatic, it really is helpful to know the specific respiratory virus that is present, because it guides treatment and prevention choices as well as management. The antigen testing is useful for screening, but remember that it does have a higher false negative than PCR, so that repeat testing is going to be important. Do an inventory now. Check how many PCR tests you have on the kits that you have on hand, and increase your inventory as needed to ensure the capacity for ongoing testing. And then also follow the CDC or your local public health authorities' directions for testing, return to work, and isolation. They're your first line resource, your LPHA, for information of what to do and provide that guidance. I do have a couple of nice tools, and these are not OHA branded. If you would like to have one of these, just email me and I'm happy to send it to you. But it's a 2-page checklist of what to do when you have a new respiratory virus outbreak in your facility. And it goes through, the precautions and notification and measures that you should be taking. So I like checklists. If you would like a copy of this, we'll get it to you. And then also another important tool in the toolkit is what we call social distancing, what I prefer to call physical distancing. We've all had our social isolation and we're kind of over it, but remind people to avoid the 3 C's, the closed spaces, crowds, and close contact less than 6 feet with people, especially during these peak respiratory periods. Avoid contact with symptomatic or positive individuals. And then wherever possible and weather permitting, move your gatherings outside into the fresh air. And when inside, use the steps that the CDC provides, some clear guidance or good guidance to improve indoor air quality and again, dilute the circulating virus in the air within the building. And then lastly, I want to just talk about cleaning and disinfection and remind folks that if a surface isn't clean, if there's debris on it, disinfection is not going to happen. So it's important to clean your surfaces. It's also important to use the right germicides. So list N for COVID-19, list K for C. difficile. But I am encouraging facilities to move towards using EPA List P products because they're effective for Candida auris, but also the ones that are effective for Candida auris will have a shorter contact time typically for COVID. Oh, it's COVID-19. Sometimes they may be a little bit more expensive, but it's also something we're trying to move people towards having that Candida auris kill as well. And to look that up once you get to the EPA list, whether you're using N or P, you would go ahead over here on the right. Number 2 is showing where that EPA registration number is. So you would just copy and paste that EPA number into the list that you're looking for its dwell time. And that's really important because in order to ensure that you're killing the organism that's on that surface, you want to make sure that it stays wet for the required contact time or dwell time. The COVID-19 germicides that are on the CRS list tend to have very short contact time, anywhere from 15 seconds to around 2 minutes. There's a couple that are longer, but those shorter dwell times are very valuable in not standing around trying to keep surfaces wet. The other thing I would encourage is to, during periods of increased respiratory illness, increase your frequency of high touch surface disinfection. The CDC says, once every 8 hours. I actually encourage high touch surfaces for, at every 4 hours. Because there's so much touching of things, doorknobs, handrails, handles, light switches, grab bars, chair arms are some of those surfaces. But also don't forget your medication carts. Make sure your med techs are disinfecting the tops and handles and drawers of their carts after each med round. And then also pay attention to those tables, nightstands, and any shared medical equipment that's used between patients. And then lastly, I just want to would like to mention that I am moving into a new role, or I've moved into a new role, and I will be doing high-risk multi-drug resistant organism infection control consults, and those are are both proactive, and I really would like to emphasize the proactive as well as those responsive ICARs when a CPO or Candida auris has been identified. If you would like an ICAR with me for MDRO, my email address is here. Please reach out. And then I'd like to give Mary a chance to just talk about what she's going to be covering. Oh, I did, again, I wanted to just to mention that I'm on the west side of Oregon. And we'll still be working with Washington County and the facilities here, just in that MDRO role. So Mary, go ahead and share your new role with Washington County.
All right, thank you again. Like I said in the introduction, I will be the infection preventionist, excuse me, for Region 1 and 2. This is all except, this is including Washington County, of course. With that, I will be working on the respiratory outbreaks, like I mentioned. So this would include flu, RSV, COVID, as well as C. diff. And I also will be working with dental and dialysis facilities. So if you have any questions or concerns and you're interested in an ICAR, like Therese was mentioning, I love prevention as well. That's all part of the game with infection prevention. So please do give me a shout. My information is listed on the slide here. If you have any questions about outbreaks, again, we are doing outbreak prevention and outbreak response. So please do get in contact with either of us depending on the organism. Thank you so much.
Okay, thank you, Therese and Mary. Appreciate it. And the slides will all be sent out afterward So we have our immunization coordinator, Sam. I'll let her go ahead and share, and then we'll have Ryan at the very end share a resource with you, and I will send out all these slides.
Alrighty, so I'll go really quick because I know we're short on time, but all the slides, like Bridget just said, are going to be sent out, and I'm always open for questions. So I'm just briefly going to go through the recommendations for our respiratory illness vaccines, RSV, flu, and COVID. I'm not going to go through pertussis today, though. So for RSV, we actually just had a slight change in the recommendation. However, that recommendation doesn't change what you would do in your facilities. The universal recommendation changed from anyone over the age of 60 to anyone over the age of 75. However, the reason it doesn't change in your facilities is anyone 60 through 74 who are considered at a higher risk, which includes living in a nursing home or long-term facility, are still recommended to get an RSV vaccine this year. So we have 3 different types of RSV immunizations available for this age group this year. I have them all listed here. It's just a single dose for each of them. And just a reminder that you do not need to get RSV annually like flu or COVID. It's a one and done. If they've gotten the RSV vaccine prior, they do not need another one. It's considered a lifetime dose. Also a note that RSV can be given at the same time as other vaccines. So if you're doing a clinic or having a provider come in and do flu or COVID in addition to RSV, that's just fine as long as it's okay with the healthcare provider for that individual. So for flu, we have our typical universal recommendation for anyone over the 6 months of age to receive the influenza booster. We do have 3 different vaccines that are approved for 65 and plus. The recommendation in general for older adults, especially those who are at higher risk, is the Fluzone high dose, just like typical years. And the reason behind that is the way that that vaccine is created. It has more antigens in it than the standard dose, which we've seen over time just gives a better immune response, especially for the older adults. And then a note that nasal spray flu is not recommended for those over 50. We also just started shipping out flu vaccine this week, so providers are going to start seeing that in their inventory, which will give a better inclination of what they're going to have available for this season for you. And then I did make a note this year, instead of being a quadvalent vaccine, which means 4 strains of flu being represented in the vaccine, there is actually only 3 this year, only because one of the strains that we typically see in the vaccine, we actually haven't seen in global surveillance since 2020. So they have taken it out to make sure that the vaccine is really hitting the strains that are within our communities. So COVID vaccine is similar to flu in that everyone 6 months and older are recommended to receive a booster. We have 2 vaccines currently available and approved by the FDA as of 5 days ago. And then there's a third one that we anticipate will be approved, but hasn't been fully approved just yet. All 3 should be available in September. And really the only change to those vaccines is they have gotten much better and honed for protecting against the specific variants that are circulating. And then I've added the fact sheets for both of those below. And then I put infection control measures, which you don't need to hear from me because you just had a really great presentation on it. And then I put a bunch of resources about the changes for all 3 of those different vaccines in case you want to know more.
Awesome, Sam. Thank you.
Thank you.
Okay, so I just entered this on-site vaccine clinic toolkit in the chat, and I want to turn it over to Ryan to let him, oh, said it failed to send. I'll put it in the chat, and I will turn it over to Ryan to introduce that resource that he created.
Great. Thank you, Bridget. Hi, everybody. Again, my name is Ryan Frick, and I work for Aging and People with Disabilities at Oregon Department of Human Services. And our team is focused on the safety of our APD consumer population and long-term care facilities and in-home care, really any of our consumers who are receiving services through APD. So this year, we are focused on advocating for the adoption of on-site vaccine clinics at all of our APD licensed facilities. And this is kind of piggybacking off of all of Jonathan's great data from earlier this afternoon relating to outbreaks and vaccine rates that we've seen year over year kind of decreasing in our facilities and amongst our most vulnerable consumers. So in a way to kind of address that and focusing on safety, we are really advocating for the scheduling of on-site clinics at our licensed facility. So that's kind of where this project began. So we met with pharmacy systems chains across Oregon this spring and summer, and I put together a long-term care toolkit that is really meant to kind of help ease the burden on the front end for our facilities when it comes to providing vaccine services for their staff and residents. So as Bridget said, that has been sent out. I have kind of presented the contents of that across the state in our regional IP meetings. So thank you everyone for having me involved in those settings. So really the contents are providing links, contact information, and details for around minimums for large retail chains in Oregon that can provide on-site vaccine services for the upcoming respiratory season. Those are initiation fee free and are typically free if minimums are met. So trying to get facilities matched up with pharmacies that are providing on-site services. All of that stuff also went out with our pharmacy lists with all retail pharmacies by county and city. We aren't really advocating for any one pharmacy system. It's mainly just increasing access and getting our facilities matched up. So that is kind of the aim of the effort. There's a lot of other resources in there on education, kind of expectation setting, or just kind of trying to ease the burden of getting these clinics scheduled on the facility side. So hopefully you've seen that. If not, we'll include it here. That's going out for.
I'm going to have to send it out. It's just failing to send, but I'm going to follow this meeting right away with an email. So you'll get it in your inbox this afternoon. Thank you, Ryan.
That'd be great. Yeah. Thanks again.
Appreciate it. Okay, the last thing is we just love your feedback on future meetings and topic ideas for future meetings. So you should see a poll. Yeah. So you can rank these in order of interest. Certainly if there's an other, we would appreciate you putting anything into the chat. Because we'd love to hear what your thoughts are, what you'd like to see in future meetings. These meetings are for you, to support you in the work that you do. So please do complete the poll. Any questions in the 1 minute we have? I think I noticed Lee had a question, and Tyler, thank you for answering that. Any other questions? Okay, well, thank you all so much for participating today. We really appreciate your interest and your collaboration. And we're always here to help. Feel free to contact us. And with that, we will wrap up the meeting. Thank you all so much.
Thank you.
Thank you.
Thank you.
Thank you.